So here the PowerPoint about the neuropharmacology. I'm going to overview all of the medication we use for nervous system disease. The first one, anti-myasthenia medication. Anti-myasthenic medication, also called anticholinesterase medication. So when a patient comes to you, and if the patient is diagnosed by myasthenia gravis, usually patient myasthenia gravis means it is autoimmune disorder or autoimmune disease, and autoimmune affect the myoneural junction. So this is, you see the picture, this is the acetylcholine, and this is the cell and receptor. The problem in that layer, this is the cell receptor. So this area, you can see the end of the nervous system and muscle layer. This junction is called myoneural junction. So myasthenia gravis, it is autoimmune, affected the myoneural junction. This layer problem, this is a molecular level problem. So in this molecular level or myoneural junction, lack of acetylcholine, right? Basically, myasthenia gravis, it is more common in the female than man. The female usually 20 to 40 years old more frequently than man. And usually when if you get a patient who is man, it is more common 60 to 70 years old. So usually the myasthenia gravis, you see the picture, this is the boy, eyelid is fall. So disease of neuromuscular junction. So this is the neuron and this is the muscle. We call neuromuscular junction. So what are the feature of myasthenia gravis? Dropping the eyelid, weakness of the extremities, legs, change of voice, very late stage we can see, change of voice, and also swallowing difficulties. So it is not mandatory every patient have a same sign and symptom. Usually, patient have a voluntary muscle weakness or increase with activities, the lethargy or tiredness, it is increased with activities. We always tell our patient to avoid the public gathering or crowd. And late stage, we see patient have a swallow problem or speech problem. So we prefer tell them to go speech therapist. So now let me go. What are the medication we use? We call anti-myasthenic medication. Before to start medication, I want to share one more point. How we diagnose the myasthenia gravis? We diagnose by positive tensilon test. It is a confirmatory diagnostic test. For the patient, we use anti-myasthenic medication or anticholinesterase agent, right? Like we use neostigmine here. Let me see and let me read. They said anti-myasthenic medication, also called anticholinesterase medication. This relieves the muscle weakness associated with myasthenia gravis. Keep in mind, this weakness increases with activities. Anti-myasthenic medication are used to treat or diagnose myasthenia gravis or distinguish cholinergic crisis from myasthenia crisis. Neostigmine, another medication we use, or pyridostigmine, used to control myasthenic symptom. Also, hydrofonium chloride is used to diagnose myasthenia gravis and distinguish cholinergic crisis from myasthenic crisis. Here, the table explain and read the name of anti-myasthenic medication. Let me read: neostigmine, pyridostigmine, hydrofonium, more commonly we use. So what are the signs of cholinergic crisis? Keep in mind, every medication has a good and bad side. Good side is therapeutic side, and bad side we call side effect or adverse effect. The common side effect of patient may be sometimes come with abdominal pain or cramps, diarrhea, and nausea. We call GI disturbance or pupillary miosis, hypotension, dizziness, increase the bronchial secretion. Also, increase salivation, increase perspiration, bronchospasm, wheezing, and bradycardia. This is the common side effect of anti-myasthenic medication. Now what are the intervention? We monitor the neuromuscular status, including reflex, muscle strength, and gait, abnormal movement or not. Monitor the client for sign and symptom of medication overdose. We call cholinergic crisis, or underdose, we call myasthenic crisis. So if a patient is diagnosed myasthenia gravis, we prescribe them anticholinergic agent. But if you give overdose of anticholinergic, that tells patient show the cholinergic crisis. If you do not give medication or underdose the medication, then myasthenic gravis will worse. We call myasthenic crisis. We re-educate instruction to the client who take the medication on time to maintain therapeutic blood level, thus preventing the weakness, because weakness can impair the client's ability to breathe and swallow. So reinforce or re-educate, train your patient to the client to take the medication with a small amount of food to prevent the gastrointestinal upset, like nausea, vomiting, or diarrhea. What next? We educate to the client to tell them to eat 45 to 60 minutes after taking the medication to decrease the risk of aspiration. Why aspiration? Because muscle weakness. So if muscle is so weak, voluntary muscle is so weak, or respiratory muscle is weak or our swallowing muscle is weak, deglutition muscle is weak, food chance to go to the respiratory tract and patient can chance to aspiration. Reinforce the instruction to the client to wear a medic alert bracelet. And note that anti-myasthenic therapy is a lifelong therapy. They have to take this medication for a long time. We could monitor the medication effectiveness, which is based on improvement of neuromuscular symptoms or strength without cholinergic sign and symptoms. Now go for endophonium test. So endophonium test can distinguish any crisis develop or not. So endophonium is injected intravenously, and endophonium test can cause bronchospasm, laryngospasm, blood pressure drop, bradycardia, and cardiac arrest. So we will be prepared to face them. Or atropine sulfate is the antidote for overdose. Diagnosis of myasthenia gravis. If patient diagnosed, what we can see, most myasthenia clients show a significant improvement in muscle tone within 30 to 60 seconds after injection, and also muscle improvement. So here, in case of endophonium test, we can confirmation. This endophonium test, sometimes we call tensilon test. So if the tensilon or endophonium test is positive, it is confirmed my patient has a myasthenia gravis. So if I ask you what is endophonium test or what is tensilon test, it is the diagnostic test for myasthenia gravis. So tensilon test or endophonium test is a pharmacological test used for diagnosis of certain neural disease, particularly myasthenia gravis. Keep it note. It is also used to distinguish a myasthenic crisis from a cholinergic crisis who undergoing treatment of myasthenia gravis. Let me recap it. As per I told, a tensilon test, also called endophonium test. Tensilon test is a pharmacological test we use for diagnosis of certain neural disease, particularly myasthenia gravis. It is also used to distinguish a myasthenic crisis from a cholinergic crisis in individual undergo the treatment of myasthenia gravis. Important for NCLEX board. Now, let me go in this flowchart. Endophonium injection, muscle strength. We check the muscle strength. If muscle strength is increased or improved, means patient is diagnosed by myasthenia gravis. Because my patient have a problem muscle weakness because of this disease. When you give them endophonium, muscle strength increase. But after giving endophonium, if muscle strength not increase, not improve, basically it is good for the patient. Muscle weakness is due to the other reason, not for myasthenia gravis. Let me continue here. The test is used to diagnose cholinergic crisis. What is cholinergic crisis? It is the overdose of cholinesterase. What are the name of the medication of anti-cholinesterase? Basically, neostigmine or progestin or mestinone, commonly used. A endophonium injection temporarily worsen the condition when the client in cholinergic crisis. It is called negative endophonium test. An endophonium injection temporarily improves the condition when the client is in myasthenia crisis. It is positive test. As I told you, positive tensilon test or positive endophonium test is a confirmation diagnostic test for myasthenia gravis. When assisting RN and a neurologist to administer endophonium, have emergency resuscitation equipment supposed to be there, right? And also atropine sulfate. Why? Because of overdose prevent. It is the antidote, right? To prevent the cholinergic crisis. Now let me go the second one, multiple sclerosis. So multiple sclerosis here, shortly called MS. Medication therapy is aimed at modifying the disease and treating acute episode or relapse or treating the symptom. So you see the picture here. This is the brain and spinal cord, central nervous system, and we can see the peripheral nervous system. So in here, you can see the healthy neuron, and this is called nerve fiber. And nerve fiber should be covered by a myelin sheath. The problem, the person who have a multiple sclerosis, the nerve fiber does not cover, or nerve fiber should cover by myelin sheath, but this myelin sheath is destroyed, damaged, and nerve fiber is exposed, and problems start, right? So what are the pathophysiology of multiple sclerosis? Easy way to say, multiple sclerosis problem in myelin sheath or demyelination or destruction of myelin sheath. Multiple sclerosis usually attack the young adult, 20 to 40 years old people. As like as myasthenia gravis, women affected more than the men. Same happen, women is more affected or frequently attacked than men in myasthenia gravis and multiple sclerosis, more common in female. Usually the patient who diagnosed the multiple sclerosis, they present with some sign and symptom of the disease, more common patient complain fatigue, patient depressed, nervousness, or loss of balance and diplopia. Let me read it. Disease modifying, disease modification decrease the frequency and severity of relapse. So the person who diagnosed the multiple sclerosis, most commonly they present to the doctor office with fatigue, depression, numbness, loss of balance, or diplopia. What is diplopia? It is the double vision. So basically, myasthenia, multiple sclerosis diagnosed by MRI, magnetic resonance imaging, or we use evoked potential studies. So disease modifying medication. What is disease modifying medication? Means like Ebonex, most common medication we use, or we use the corticosteroid or cyclophosphamide. So this is disease modifying agents. So that disease modifying medication reduce the frequency and severity of relapse, reduce the brain lesion, increase future functional capability, and increase the overall quality of life. The two main groups of disease modifying medication are, one is immunomodulator, and other is immunosuppressant. As I told you, the medication we use Ebonex or cyclophosphamide or corticosteroid. The treating acute episode usually consists of giving high dose glucocorticoid or corticosteroid intravenously to suppress inflammation, or giving the gamma globulin intravenously. Treat the symptom of multiple sclerosis can be done with a variety of medication, or medication can be changed if unfavorable effort occur. What else? Here we can see the list of medication more commonly we use. One is immunomodulators, immunosuppressant, monoclonal antibody, and potassium channel blocker. What are the name of drugs under immunomodulators? Like interferons. Usually we use beta 1A or 1B, or pig interferons, right? Also, fingolimod or dimethyl fumarate, common immunomodulators. Immunosuppressant, usually mitoxantrone. Also, we use cyclophosphamide. Monoclonal antibody. Basically, we use alemtuzumab or natalizumab. Alemtuzumab is more frequently used. Potassium channel blocker like delfam, predin, most commonly used to improve the working. Now, medication to treat the symptom of multiple sclerosis. bladder and bowel dysfunction, we can use the laxatives or Docusset. Patient if fatigued, give them amantadine, or if patient is depressed, we give them sertraline, antipsychotic, fluoxetine. Sexual dysfunction, give them sildenafil, it is Viagra, or neuropathic pain, we give them gabapentin or carbamazepine. Carbamazepine also we can use anti-seizure. Gabapentin used for neuropathic pain. Another medication, sometimes gabapentin has a side effect to the patient. They see a bad dream, nightmare. They wake up, panic. So we use the pre-GABA. So what are the side and adverse effects about the immunomodulators? Patient has a flu-like reaction, hepatotoxicity, myelosuppression, injection site reaction, depression, and neutralizing antibodies. So the person who take immunomodulators, that immune system get disturbed. So sometimes patient presents a flu-like reaction, fever, little bit cough, or this medication has hepatotoxic. It is good to check liver function test, or bone marrow gets suppressed. We call myelosuppression. Injection site reaction, local inflammation, tender, redness, or patient sometimes present with depression. Also, neutralizing antibodies. What else? Immunosuppressant like cyclophosphamide. This medication can cause myelosuppression. So bone marrow can produce red cell, white cell, platelet. If our myeloid series gets suppressed, that patient develop pancytopenia, infection most common, anemia developed, or cardiotoxicity, fetal harm, also reversible hair loss, injury to the gastrointestinal mucosa, nausea, and vomiting. In case of female, start menstrual irregularities. What else? Anti-Parkinsonian medication. Easy way to say, medication used for Parkinson disease. So Parkinson disease, shortly called PD. P for Parkinson, and Parkinson and D for disease. Another way we can say, in Parkinson, lack of dopamine. The real pathophysiology of Parkinson disease is unknown. Maybe the link to environmental, or usually the patient who diagnosed the Parkinson disease, they can give the head injury, head trauma, or chronic antipsychotic use, or patient decrease the dopamine level. So anti-Parkinson medication basically increase the dopamine in the patient. Usually who is affected? Men affected more than female, but myasthenia gravis, female is more. Multiple sclerosis, female is more. But Parkinson, men affected more than female. Usually, it is more common elderly patient, 50 plus. The common symptom of Parkinson's disease, the disease is gradual onset. Patient present with tremor at the rest, rigidity, bradykinesia, and shuffling gait, right? What are the medication we use? Anti-Parkinson medication restore the balance of neurotransmitter acetylcholine and dopamine in the central nervous system, decreasing and slowing the sign and symptom of Parkinson's disease to maximize the effect or maximize the client functional abilities. So how we diagnose a patient who are Parkinsonian? Patient give the history. Usually 2 out of 3 more common signs if present, we can say patient have a Parkinson's disease. So here we say this medication include dopaminergics, which stimulate the dopamine receptor, and anticholinergics, which block the cholinergics receptors, and the catechol O methyltransferase inhibitor, which inhibit the metabolism of dopamine in periphery. Keep in mind, when you give the treatment to anti-Parkinson patient, we try to control the symptom, right? We give patient to levodopa, or we give them another medication called amantadine, selegiline, right? Most common one. So here the picture showing normal neuron, and this is the one terminal part of the neuron. This is the another neuron, the beginning part, receptor is there. So the terminal neuron release the dopamine, and this dopamine is supposed to received by receptor and get inside the cell body or another neuron, and then transmit the information. So dopamine is a neurotransmitter. So the problem either less of the dopamine or receptor does not receive the dopamine. And when dopamine are not transmitted or less dopamine means neurotransmitter deficiency. So here we can see, so in the picture number 1, we can see so many dopamine or neurotransmitter, but person who is Parkinson, they have a less, very few dopamine because patient is lack of dopamine, deficiency of dopamine. And patient develop sign symptom like tremor, slow movement, rigidity. Usually tremor at rest, muscle rigidity, patient present with bradycardia or shuffling gait, or we can say pill rolling, most common sign. What are the medication we use? We use amantadine, we use bromocriptine, carbidopa, levodopa. The levodopa, sometimes we call Sinemet, and use with some precursor. If patient has a glaucoma, it is good to avoid levodopa. levodopa is medication, but they themselves does not cross the blood-brain barrier. So you have to give with carbidopa, and carbidopa help them to cross the blood-brain barrier. Other medication, we use amantadine, right? Or we use the razagiline or selegiline, right? More commonly. But control the symptom is important. Here showing Parkinson's disease medication, how work. Dopamine release, dopamine receptor here. So here showing the COMT inhibitor preserve the levodopa. Levodopa replace dopamine, and dopamine agonist mimic the dopaminergic activities. Dopamine producing neuron here, and also MAOB inhibitor preserve the existent dopamine. So here in this picture showing this blue one is levodopa, and this is the dopamine, and this one is a dopamine agonist, right? Now we go for dopaminergic medication, some explanation. Dopaminergic medication stimulate the dopamine receptor and increase the amount of dopamine available in the central nervous system and improve neurotransmission of dopamine. So dopaminergic medication stimulate the receptor. They capture more dopamine, and dopamine transmit from outside to inside the cell. Dopaminergic medication are contraindicated in clients with cardiac, renal, and psychiatric disorder. Carbidopa, levodopa take with a monoamine oxide inhibitor or antidepressant can cause hypertensive crisis. So what we do, it is good not to give levodopa and carbidopa with monoamine oxide inhibitor, or not to give with antidepressant. Why? Because they chance to develop hypertensive crisis. What are the common side and adverse effect? So what are the difference between side effect and adverse effect? Side effect is sometimes common, or side effect is expected, but adverse effect sometimes cause a very bad condition, which is not unexpected, but some individual patient can show up. Patient develop involuntary body movement or dyskinesia. Patient develop chest pain, nausea, vomiting, urinary retention, constipation, sleep disturbance, insomnia, or orthostatic hypotension and dizziness, confusion, mood change, hallucination, and dry mouth. So if your patient diagnosed Parkinson's disease, and if we give them dopaminergic medication, what we have to observe and what are the intervention? We monitor vital signs, determine the risks of injuries. If patient fall, we could prevent it. The client is instructed to take medication with food if nausea or vomiting occur, and check for the sign and symptom of Parkinsonism, such as rigidity, tremor, akinesia, bradykinesia, a stopped forward posture, or abnormal gait we call suffering gait, or marked face. We monitor for the sign of dyskinesia, right? Sometimes patient has a movement problem. Sometimes patient has a difficulty of speech. The client is instructed to report the side and adverse effect, right? If patient have a dyskinesia, also we could monitor to the healthcare provider. So first of now we said so what is dyskinesia, my friend? This is the abnormality or impairment of voluntary movement, right? We monitor the client for improvement in the sign and symptom of Parkinsonism without the development of side and adverse effect from the medication. What else? The client is instructed to change the position slowly to minimize the orthostatic hypotension, or reinforce instruction to the client to not discontinue the medication abruptly. So it is good not to stop medication suddenly. Reinforce the instruction to the client to avoid the alcohol. The client is informed that urine or perspiration may be discolored and that this is harmless but may strain cloth. The client with diabetic mellitus is advised that glucose testing should not be done by urine testing because the result will not be reliable. Now, continue. We re-educate the instruction to the client who taking carbidopa, levodopa together, or to divide the total daily prescribed protein intake among all meals of the day. High protein diet interfere with medication available to central nervous system. When administering levodopa, the client is instructed to avoid excess vitamin B6, right? So B6 intake excess prevent the medication reaction. So anticholinergic medication. Anticholinergic medication block the cholinergic receptor in the central nervous system, thereby suppressing the acetylcholine activities. So our patient has a problem, lack of dopamine or excessive acetylcholine. So anticholinergic, or they block the receptor, so suppress the acetylcholine activities. Anticholinergic medication reduce tremor and drooling, but have a minimal effect on bradykinesia, rigidity, and balance abnormalities. Anticholinergic medication are contraindicated in client with a glaucoma. So if patient have a glaucoma, it is good to avoid the cholinergic medication or levodopa. The client with chronic obstructive lung disease can develop dry cough, thick mucus secretion. What else? Anticholinergics, what commonly we use? We use benzotropine, or we could use trihexyphenidyl hydrochloride. Also, we use carbidopa-levodopa combination, antracapone or tolcapone. Anticholinergic medication side and adverse effect. Patients sometimes present with blur of vision, dryness of dry nose, mouth, throat, and respiratory secretion. Also increase the pulse rate, palpitation, dyskinesia, or patient develop tachycardia. Constipation are common, urinary retention is common, restless, confusion, depression, and hallucination. Also, photophobia. So if your patient take anticholinergic, it is good to tell them to avoid the sunlight. What else? What are the intervention? Monitor the vital sign, determine the risks for injuries, monitor the client for improvement in sign and symptoms, check the client bowel and urinary function, monitor for urinary retention, constipation, and paralytic ileus development. Monitor for involuntary movement. The client is encouraged to avoid alcohol, smoking, caffeine, and aspirin to decrease the gastric acidity. Reinforce instruction to the client to consult with the primary healthcare provider before taking any non-prescribed medication to avoid the drug-drug interaction. The person who is diagnosed diagnosed Parkinsonian disease, and you give them anti-Parkinson medication, it is good to instruct to the client to minimize the dry mouth by increasing the food intake and using ice slips, hard candy, or gum, so it can avoid. Reinforce the instruction to the client to prevent constipation by increasing fluid and fiber in the diet. Reinforce instruction to the client to use sunglasses in direct sunlight because to possible photophobia. So how we avoid the photosensitivities or photophobia? Tell your patient wear a long sleeve dress, wear the sun protective lotion or sunglasses. Reinforce the instruction to the client to have routine eye examination to assess for intraocular pressure. If an anticholinergic medication is discontinued abruptly, the sign and symptom of Parkinsonism, such as rigidity, tremor, echinacea, bradykinesia, or a stop forward posture, shuffling gait, or mask-like face may intensify. So it is good to not stop the medication suddenly. Now let me talk anti-seizure medication, right? So sometimes NCLEX board asks the question, seizure precursor. It is very important to management of seizure. So anti-seizure medication, before to go, I want to tell you what is seizure. A seizure is a uncontrolled electrical activities between brain cells that causes the temporary abnormalities in muscle tone or movement. We call stiffness, twitching, or limpness. Sometimes seizure can cause behavioral problem, sensation problem, or state of awareness problem, right? What are the most common of seizure? The most common causes of seizure are epilepsy. But not every person who have a seizure has epilepsy. Sometimes seizure may be caused or triggered by high fever, which can be associated with an infection such as meningitis. Most common, right? So keep in mind the seizure are several types. Sometimes we call absence seizure, or it is also called petit mal seizure, tonic-clonic or convulsive seizure, atonic seizure, clonic seizure, or tonic seizure, or myoclonic seizure, different types. But here we are going to what are the medication we use for the seizure. So here talking tonic phase, this one is the clonic phase, and that one is post-ictal confusional fatigue. So anticonvulsant medication are used to depress the abnormal neuronal discharge and suppress the spread of seizure to adjacent neuron. As I told you, a seizure basically uncontrolled electrical activities between brain cell or abnormal electrical activity between neuron or nerve cell. And that causes temporary abnormalities of muscle tone and movement, behavioral problem, sensation or state of awareness problem, right? So anticonvulsant medication should be used with caution in the client taking anticoagulant, aspirin, sulfonamide, cimetidine, and antipsychotic drugs. Absorption is decreased with the use of antacid, calcium preparation, and anti-neoplastic medication. Here showing the list of anti-seizure medication and therapeutic serum range like carbamazepine, clonazepam, it is tranquilizer, or we use ethosuximide, lorazepam, phenobarbital, or phenytoin. So NCLEX board sometimes asks the therapeutic range of phenytoin. It is 10 to 20. Phenobarbital, 15 to 40. Lorazepam is very range, safe, right? or carbamazepine, 3 to 14. Now, what are the intervention for the client on anticonvulsant? Initial seizure precursor we could follow, monitor urine output, monitor liver and renal function before to give anti-seizure medication. Also, we need to check the blood level because of therapeutic index check. Monitor the sign of medication toxicity, which would include central nervous system depression, ataxia, nausea, vomiting, drowsiness, dizziness, restlessness, and visual disturbance. If a seizure occurs, we could monitor seizure activities, including location and duration. Protect the client from hazard in the environmental during a seizure. The client education. Take the prescribed medication in the prescribed dose and frequency. Take with food to decrease the gastrointestinal irritation, but avoid milk and antacid, which impair the absorption. So it is good anti-seizure take with food to prevent gastric upset. But same time, better to avoid milk and antacid because antacid impair absorption of anti-seizure medication. If taking liquid medication, always check it for mixture. Do not discontinue the medication suddenly. Avoid alcohol with anti-seizure medication. Avoid over-the-counter because of drug interaction. It is good patient wear medical advice. Use some caution when performing activity that require alertness. Maintain blood oral hygiene and use a soft toothbrush. Maintain preventive dental checkup. Maintain the follow-up healthcare visit with periodic blood study related to determining toxicity. Monitor serum glucose level. Urine may be harmless pink red or red brown because of anti-seizure medication. It is good to report if we see the symptom of sore throat, bruising, nose bleeding, which may indicate blood dyscrasis. If platelet go down, patient may be present with nosebleed, bruising. If white blood cell go down, patient may become with sore throat, fever, or sign of infection. If red blood cell go down, patient may be present with anemia. Inform the healthcare provider if side and adverse effect occur, such as bleeding gum, nausea, vomiting, blurred of vision, right? Difficult of speech, rash, or dizziness. Anti-seizure medication, hydrotoin, like phenytoin. Phenytoin is most common anti-seizure medication. Hydration are used to treat partial or generalized tonic-clonic seizure. Phenytoin also used to dyskinesia. The side and adverse effect, sometimes patient present with gingival hyperplasia, right? Gum hypertrophy, or sometimes patient present with confusion, slur of speech, or here we see the sedation, drowsiness, blur of vision, nystagmus, headache, right? So basically, the anticonvulsant medication, we can use phenytoin, phenobarbital, valproic acid, or gabapentin. Here we are talking about the phenytoin. It is very important. NCLEX board asks, if you give phenytoin, do not give with food and do not take with oral birth control pill. If you are giving this medication IV, you can only give with sodium chloride. Very important. What next? Side effect, blood dyscrasis, means decrease the platelet count and decrease the white blood cell. Elevate blood glucose level. Alopecia means hair loss, or hirsutism, excess facial hair, and skin rash or pruritus. What is nursing intervention? Right? It is very important if our patient take the anti-seizure medication. What we educate them about anti-seizure medication? First of all, let me read the name of anti-seizure. We use carbamazepine, we use gabapentin, we use lamotrigine, we use carbamazepine, we use valproic acid, phenobarbital, or topiramide, right? First of all, if we give this medication, what we educate our patient? In general, all anticonvulsant, if you give, all anticonvulsant can become toxic in the body system or can cause dependency issues. They can cause drowsiness and should not taken with antacid, which will decrease the absorption or can elevate the blood glucose level or may change the urine to a light rust color, but it is not dangerous to the patient. Also keep it note, and all anticonvulsant will still allow to the patient to have a seizure despite being on medication watch for them. Patient should also be educated to wear their medical ID bracelet. Do not give any of this medication before electroconvulsion therapy. Keep in mind, if your patient is on anticonvulsant, we always initiate the seizure precursor. What next? So phenytoin is an anticonvulsant. So if you give phenytoin for seizure or convulsion, what are the side effects? The most common side effect, patient may develop blood dyscrasis, decreased platelet count, decreased white blood cell count, or decreased red blood cell count, thrombocytopenia, or neutropenia, or anemia developed. Elevated blood sugar level. So if your patient are diabetic, it is good to tell them adjust the insulin level. Patient develop alopecia or hirsutism. Alopecia means hair loss, but hirsutism means excessive hair growth or excessive facial hair growth in female patient, or skin rash or pruritus. What are the intervention? So educate your patient. If they took phenytoin, do not give with food. Do not take with oral birth control pill, because oral birth control pill or contraceptive will not work. If you give this medication IV, you can only give with sodium chloride. Tube feeding may interfere with absorption of enteral form of phenytoin and diminished the effectiveness of the medication. Therefore, feeding should be scheduled as far as possible from the time of phenytoin administration. We also monitor therapeutic serum level to assess for toxicity. Also, it is good to monitor for sign of toxicity. What else? Monitor the ataxia, means abnormal movement or gait. Reinforce instruction to the client to consult with primary healthcare provider before taking other medication to ensure compatibilities with anticonvulsant. Phenytoin must be given slowly to prevent hypotension and cardiac dysrhythmias. Also, it decreases the effectiveness of some birth control pills and can have teratogenic effect if taken during pregnancy. Right? Now, go next, barbiturate. Barbiturate or phenobarbital we use as an anticonvulsant or anti-seizure. So barbiturate decrease the blood pressure and respiratory rate. If you give phenobarbital or barbiturate, vitamin D supplement may be needed. It is NCLEX tips. Barbiturate are used for tonic-clonic seizure and also acute episode of seizure caused by status epilepticus. Barbiturate also may be used as a adjust to anesthesia. Barbiturate we also use as a tranquilizer or anti-anxiety medication. So what are the side effect or adverse effect of barbiturate? Sedation, ataxia, dizziness, mood change, hypotension, respiratory depression, or tolerance of medication. So dependency developed, right? So vital sign alteration, decrease blood pressure, convulsion, confusion, dizziness, distension of bladder, or retention of urine is a common adverse effect. So benzodiazepam are used to treat absence seizure. Absence seizure are one of the type of seizure. Diazepam or lorazepam are used to treat status epilepticus, or diazepam also used for anxiety or skeletal muscle spasm. Clorazepam is used to adjunctive therapy for partial seizure. What are the side and adverse effect of benzodiazepam? Sedation, drowsiness, dizziness, blur of vision, bradycardia, or can occur when admin rapidly by intravenous route. Medication tolerance or drug dependency or blood decrease is developed, decrease platelet count, decrease white blood cell count, and if you take too much, patient develop hepatotoxicity, or flumazenil reverts the effect of benzodiazepam. So benzodiazepam or flumazenil is an antidote, right? Everybody know the insulin. What are the antidote of insulin? Glucagon. Morphine is an opioid. What are the antidote of morphine? Naloxone. Acetaminophen. What are the antidote of acetaminophen? N-acetylcysteine. Imagine a patient has a high potassium. We give them insulin or sodium polystyrene sulfonate, the antidote of high potassium. Same as flumazenil is an antidote of benzodiazepine. What else? Next is muscle relaxant. We can use succinimide or ethosuximide. Succinide are used to treat absence seizure. What are the side and adverse effect? Anorexia, nausea, vomiting, blood dysphasia. Now, valproic acid or valproate, right? So valproic acid we use as an anticonvulsant, right? Or if you give valproic acid, we need to check the liver function test because it is hepatotoxic agents. We watch for abdominal cramping, And valproic acid may cause suicidal thoughts. And this valproic acid are used to treat tonic-clonic seizure, partial seizure, or myoclonic seizure. What are the side and adverse effects? Patient transient nausea, vomiting, indigestion, sedation, drowsiness, dizziness, pancreatitis, blood dyscrasis, and hepatotoxicity. The other anti-seizure medication is called immunostilbene or immunostilbene, are used to treat seizure disorder that have not responded to the other anticonvulsant. These are used to treat trigeminal neuralgia. So what are the common side effects patient developed? Seizure, dizziness, or constipation, diarrhea, rash, visual abnormalities, blood dyscrasis, and also headache. Like blood dyscrasis also caused by phenobarbital, also caused by phenytoin, also by valproic acid. Now, here the list of anticonvulsant medication. We can use carbamazepine, gabapentin. Let me talk about the gabapentin. Gabapentin may cause memory problem. And gabapentin we use anticonvulsant. Gabapentin we also use neuropathic pain. So gabapentin do not take with antacid. And gabapentin will help with symptom of restless leg syndrome. So for the NCLEX board exam, there are some common information every student must know about anticonvulsant medication. All anticonvulsant or anti-seizure can become toxic in the body system, or they easily can cause dependency issues. All anti-seizure can cause drowsiness. So if your patient take this medication, tell them not to go for driving or heavy machinery works where need alertness. And anticonvulsant or all anti-seizure should not be taken with antacid, which will decrease the absorption. And all anti-seizure can elevate the blood glucose level. So educate your patient if they are diabetic to adjust the insulin doses. All anticonvulsant or all anti-seizure may change the urine to light rust color, but it is not danger to the patient. Keep in mind, all anti-seizure medication will still allow the patient to have a seizure disorder despite being on medication watch for them. And patients should also be educated to wear their medical ID bracelet. What else? all anti-seizure or all anticonvulsant do not give any of this medication before electroconvulsion therapy, right?